Hi, good afternoon, everybody. Thank you very much for the invitation to talk today about colorectal peritoneal metastasis. This is a huge subject with a amount of different aspects, and I will try to focus on basic things related to this metastasis process, and also, of course, on treatment and on recent data. Colorectal cancer is the third in Europe, and we know that half of these patients at least will develop metastasis. Adjuvant systemic chemotherapy increased survival in stage 3 patients, non-metastatic patients, probably by decreasing the occurrence of this metastasis. Peritoneal metastasis we will see in details, but this is the site with the worst prognosis, and it could be, of course, associated to other metastatic sites. At least 1/4 of these patients present with no extraperitoneal metastases, meaning that for at least a moment, this pathology is a locoregional disease, and this is the basis of part of treatment proposed. The route of dissemination, the pathophysiology, remains unclear, with two main ways incriminated: the transthalamic spread, mainly with a perforated tumor, and the hematogenous one. A subgroup of patients, we will speak about it just a few, is patients without peritoneal metastasis at time of treatment, but they are at high risk of peritoneal recurrence in the 2 years following the treatment. A word about epidemiology. What do we know about colorectal peritoneal metastasis? On this review of nearly 3,000 patients with colorectal cancer, 30% had peritoneal metastasis, 60% synchronously, 40% metachronously, and you see that in patients with synchronous peritoneal metastasis, nearly the half had extraperitoneal associated metastasis. What about the question to know if there is a difference between colon cancer and rectal cancer, or about the risk to develop peritoneal metastasis? For a long time we thought that colon cancer gave more peritoneal metastasis, but finally from this study we knew that the incidence is almost the same. And we knew from this paper also, published in Annals of Surgery in 2006, that at this moment, with the former systemic chemotherapy protocols, mainly based on 5-FU and leucovorin, the median overall survival was around 6 months. A word about those patients with the peritoneal risk. This is patients that they were well defined by the team from Paris, from IGR in 2013. Those patients with localized peritoneal metastasis at time of the treatment of the primary tumor, or patients with ovarian metastasis or perforated tumor, other type of T4, non-perforated but T4 at least, and also probably that we can speak in this group of colloid tumor. These patients have a higher risk of peritoneal recurrence, and we thought for a long time that it was depending of the incriminated factor around 30 to 50%. With one of the study led by the French RENAP group, which is a multicentric net of center in France that are specialized in peritoneal surface malignancies, with the prospective multicentric study studying those patients and the effect of CRS and IPEC in those patients, an ancillary study evaluated the laparoscopy to determine if it is a good way to evaluate the peritoneal metastasis spread. 50 patients were included in this ancillary study. And this is patients that are at risk, but with no peritoneal metastasis known at the moment of the exam. And we were surprised to discover that in between the 2 years from the initial treatment of the primary tumor of patients that had systemic chemotherapy, mainly FOLFOX, 68% of these patients had lesions of peritoneal metastasis proved by pathology. Now to continue on the basic data upon peritoneal metastasis, this very, very important publication dated from 2016 from Jan Franco. He used the ARCAD database to study the effect, the response to systemic chemotherapy in patients with metastatic colorectal cancer, meaning that he compared patients with liver metastasis, patients with peritoneal metastasis, and patients with both. And we see clearly on this graph that the purple line is patients with peritoneal metastasis, and they have a median overall survival of 16 months, while patients with lung metastasis have a median, so this is the blue line, of 25 months of median overall survival, and patients with liver metastasis are in between. And when metastatic sites are associated in same patients, we see that the presence of peritoneal metastasis confers always the worst prognosis. So, facing such an aggressive disease, but in at least a quarter of patients loco-regional, many doctors, mainly surgeons, decided to struggle this metastasis. You have on the left Professor Spratt that performed the first IPEC from history. On the right, the Professor Gilly that is very important to us because he was from Lyon and he did probably the first IPEC in Europe. And of course, Professor Paul-Henri Sugarbaker that developed every aspect of curative intent treatment of peritoneal metastasis. Those surgeons had, of course, spirit of adventurer and inventor because they faced a pathology that was considered as a dead-end issue for a long time. How did they reflect? First, they considered that thanks to the peritoneal plasma barrier, which is an anatomical constituent of the peritoneal, we can use higher drugs concentrations inside the peritoneum. And thanks to this higher concentration with a lower systemic passage, we reach high AUC ratio when you compare concentration over time in the peritoneum to the same concentration over time in the systemic part. And with this, we can reach penetration of drugs of 1 to 2 millimeters inside the nodules. This is what you see on this captation from microscopic electronic. Very soon, they had the idea to add hyperthermia to this intraperitoneal treatment because hyperthermia has a proper cytotoxic effect and also enhances drug penetration and drug activity. To standardize a little bit the procedures, Professor Sugarbaker created the PCI score, Peritoneal Carcinomatosis Index, which is based on the very simple way to separate abdominal cavity into 13 parts, and each part is credited from 1 to 3 points to have the score over 39. At the end of the cytoreductive surgery, we have to quote the completeness of cytoreduction score, which is the CC score, very important. And you see that patients with CC0 or CC1, meaning that you have metastatic residue of less than 2.5 millimeters. This is for many patients considered as a complete surgery. So the treatment is based on first the treatment of the macroscopic disease. This is the cytoreductive surgery. This is based on peritonectomy procedures, as you can see on the first photograph, and also on organ resection when you cannot split the peritoneum from the organ. The second point is to treat the microscopic disease, the disease that you know that is present upon the peritoneum, but that you cannot drop off. This is the concept of intraperitoneal chemotherapy that you can use with hyperthermia, like for IPEC, but many ways to perform this intraperitoneal chemotherapy exist. And finally, of course, you have the treatment of the systemic disease. Here on the photograph, you see that you can do IPEC with a closed technique, meaning you put drains, close the abdomen, and perform IPEC in this way, or the open technique where the surgeon is shaking for a long time the bass. What about clinical data? We have in the field of peritoneal metastasis very few randomized prospective data. This is the first, dated from 2003. This randomized data performed by the Dutch compared upon 105 patients with peritoneal colorectal metastasis, 51 patients with the standard treatment considered as systemic chemotherapy with mainly 5-FU and leucovorin, and sometimes surgery, but surgery just palliative surgery. 54 patients treated with cytoreductive surgery and IPEC. And the results were, I would say, of course, far in favor of CRS and IPEC. 5 years later, they reanalyzed their results on the same cohort and confirming that with a median follow-up of 8 years, the results was maintained. The problem of this trial is that it is not the same surgical treatment in both arms. So we, in fact, evaluated the comprehensive treatment with CRS and IPEC and not the fact that adding IPEC to CRS. And that, of course, systemic chemotherapy protocols were without oxaliplatin or irinotecan. This was a little bit corrected by Dominique Elias a few years later, but in a retrospective way. He compared in a case control analysis patients with a modern systemic chemotherapy protocol to patients with CRS and IPEC. And he found that with modern systemic chemotherapy protocol, patients with colorectal peritoneal metastasis reached a median overall survival of 24 months, while with the curative intent technique, it was nearly 63 months in highly selected patients, of course. Years after years, many teams added their experience with larger cohort, but all these studies are retrospective. And you see that they reached median overall survival from 30 to 40 months. And this was obtained at the cost of high rate of severe morbidity and also mortality. From this series, we know that main prognosis factors in the field of colorectal peritoneal metastasis are, of course, the CC score, the PCI, the presence of a bowel obstruction at the beginning of the clinical story, and the presence, of course, of extraperitoneal metastasis. And we have here the beginning also of a biologic factor with a pro-tumor differentiation, presence of a signet ring cell, and a lymph node involvement. The final question for general data upon peritoneal metastasis is, can we cure peritoneal patients with peritoneal metastasis? still the team from Paris, from Dominique Elias and Diane Goerre, they evaluated on their database retrospectively patients and considered patients cure with no recurrence at 5 years of follow-up. And they proved that 16% of patients in their cohort could be considered as cured. And the only prognosis factor predicting cure was a PCI lower than 10, meaning a very not extended peritoneal metastasis. So most of those patients, 85%, will relapse. And we know also which is the spectrum of those relapse. This is almost 1/3 isolated peritoneal metastasis that arrive with a delay of 13 months. Also isolated distant metastasis without local regional recurrence, about 11 months after the primary surgery. And finally, multi-site recurrence. And you can see that over the years, we have here 3 periods of treatment. Number of patients increased, that meaning that in specialized center we were little by little more experienced and more ready to operate on patients with wider peritoneal metastasis. And the recurrence is decreasing from 80% to 70%. And very interestingly, patients, little by little, also with gaining in experience, could benefit from a second surgery with good cytoreductive surgery with good results. Now, a word on the Prodigy 7 trial that is not published yet, but that has been presented in last ASCO meeting by the PI, François Quenet, that kindly allow me to use his slides today. This was a phase 3 trial for colorectal peritoneal metastatic patients to compare CRS with CRS and IPEC after a complete cytoreductive surgery. Those patients had either preoperative, either postoperative, or both systemic chemotherapy with modern protocol and stratification. It was a multicentric trial. Stratification was made on center, the residual tumor status, and perioperative treatments. Very important, the fact that after long discussions, we finally choose the protocol of IPEC based on oxaliplatin intraperitoneally at high dose oxaliplatin, 460 milligrams per square meters, with only 30 minutes of hyperthermia. This treatment intraperitoneally is completed by perfusion intravenously of 5-FU and folinic acid. This is called the Elias protocol. Endpoints was primary overall survival, and secondary was the classical one, and of course the study of complications. The main hypothesis was to gain on median overall survival 18 months, which was probably too much, and the sample size was determined with this hypothesis. Finally, 265 patients were randomly assigned to the different group with intention to treat analysis. Groups were comparable for main factors, and notably for the location of the primitive tumor. You can constate that appendiceal adenocarcinoma was an exclusion criteria. Here, just to focus on the repartition of the PCI between the two groups, because it is an important point. There were no stratification on the PCI, and we see that there is a little discrepancy for PCI between 11 and 15. We had 30.5% of patients in the IPEC group, while it was more than 20% in the non-IPEC group, and it was 30% for higher PCI from 16 to 24, so higher burden, metastatic burden, while it was 20% in the non-IPEC group. You see also that the rate of complete cytoreductive surgery was very high in both groups, around 90%. The safety, the analysis of mortality, you see that we had at 60 days, 4 patients in the IPEC group that died because of the treatment, and it was 3 in the non-IPEC group. It was not statistically different. What we can note here on the post-operative complication is that in the IPEC group, 8.3% of patients present peritoneal hemorrhagia that we know now that is probably linked to the use of oxaliplatin intraperitoneally. And in the non-IPEC group, it was 2.3%. It was non-significant, but the p-value was 0.051. And, excuse me. Now, of course, a very important point, at 60 days after surgery, the rate of severe complications, meaning of a grade upper than 3, was 24% in the IPEC group, while it was 40% in the non-IPEC group, and this difference was significant. On overall survival, the main endpoint, we see that we don't have any differences between the CRS group and the CRS and IPEC group, with 41.7 in the IPEC group and 41.2 in the non-IPEC group. This is, we have a little difference for the relapse-free survival, because you see on the curve that at the beginning of the survey period, you have you seem to have a little advantage in the IPEC group, but at least the difference is non-significant. If we look into the subgroups to be able to interpret these results, we see that for the group of PCI between 11 and 15, the difference of survival was significant and in favor of the IPEC group, with 10 months of difference. Of course, the trial was not designed to interpret results like this, and the group were very small. I think there were 28 patients in the non-IPEC group with PCI between 11 and 15, while it was 18 patients in the IPEC, in these IPEC subgroups. What now we will comment on the result from this Prodigy 7. First of all, we participated in this trial, and it was a very well-conducted trial with no problems of recording of data. We see that CRS alone achieves an unexpected good survival result, which is very good for patients, meaning that when they are taking in charge in specialized centers, we can reach median overall survival of 41 months. You remember that 15 years ago, it was 6 months with 5-FU and leucovorin. IPEC with oxaliplatin at high dose, because other protocols with oxaliplatin exist, but this protocol at high dose for only 30 minutes of hyperthermia does not improve results and even increase long-term postoperative complications. So for our former adventurer, it was very bad news, because there were really believing that HIPEC could achieve to have better results than CRS alone. So what can we do now if we are going into detail? If we look at methodological considerations, we can see that perhaps when considering particularly peritoneal metastasis, the two groups were not totally comparable. Median PCI, there were just a point of difference, but we know from two data. The first was the French registry that studied more than 500 patients and proved that when you upgrade the PCI for 1, you lose 5% of 5-year overall survival. And recently, Schneider proved on the multicentric analysis that 1 point more on PCI was a bad prognosis factor significant in a multivariate analysis. The basal hypothesis was wrong, of course, we saw it, but in the good sense for patients, which is still good news. And after regarding more closer the patients we included in, probably that some patients with very low PCI of 1, 2, 3 were patients with more local regional recurrences or lymph node recurrences more than authentic peritoneal metastasis that, of course, won't benefit from HIPEC. And the main issue is probably the role of oxaliplatin in these results with the so-called ELIAS protocol. We know that we have more postoperative bleeding. We will see later the precise data, and that they have negative impact, the negative impact of transfusion. And the same year, in January this year, we had the first randomized trial randomizing CRS versus CRS and HIPEC, but in ovarian cancer in interval surgery. And HIPEC in this protocol was used for 90 minutes with the drug delivered in 3 fractions with lower temperature and a drug, cisplatin, that is known to be highly enhanced by hyperthermia, while fundamental data regarding oxaliplatin are less clear. In this protocol, of course, this is ovarian cancer. This is not the same histology, but in this protocol, CRS and HIPEC improved survival of nearly 1 year and mainly did not increase severe complications. The rate was exactly the same in the two groups. The American Society of Peritoneal Surface Malignancies evaluated 2 years ago mitomycin C versus oxaliplatin in more than 500 patients treated for peritoneal metastases of colon cancer. And they saw that the classification used is a little bit different. This is the PSDSS, and this is we can consider that PSDSS group 1 or 2 is patients with a low burden of peritoneal metastasis. And you see that in this group, there were a far advantage of mitomycin C. On the overall cohort, the difference was not confirmed. Here a paper from the team from Milan that proved that post-operative complications after CRS and HIPEC affect dramatically the prognosis of patients. You can see that the 5-year overall survival of patients without major complication was nearly 60%, while it was 12% of patients complicated. Here is a study led on the French RENAP group, multicentric, with 700 CRS and HIPEC patients, different histologies, but studying the oxaliplatin protocol. And you see that we have 15.7% of abdominal hemorrhagia in the post-operative period versus 2.6% with protocol without oxaliplatin. This hemorrhagia appears with a median delay of 9 days. and it was more frequent with extended peritoneal metastasis. Here, the team from Sydney, from David Morris, they proved that there were dramatic differences when patients after CRS and IPEC should have benefited from allogenic blood transfusion. Here, this is the same principle of analysis, but meaning also that severe morbidity was incriminated in the prognosis. So now just a word about the patients that have peritoneal and liver metastasis. What can we do for those patients? We know that now for nearly 10 years that we can operate it on these patients at the question that liver metastasis is not too extended. We can resect it up to 4 segments of liver associated to cytoreductive surgery and IPEC with results. It depends on the study, but this one was from the team of Lorimier, and you see that the survival is almost the same depending on the radicality of the surgery. Quality of life has been widely studied after CRS and IPEC. Main information is that physical and wall functioning scores, they decreased up to 3 months after surgery, but returned to baseline at 6 months, and this is something that is very constant. We can see with patients that 6 months after surgery, after CRS and IPEC, they have recovered their quality of life. And we saw also, this is a paper from Shanghai, that major complication had no impact of quality of life at 6 months. So how do we have to do now before reaching new trials? We have to improve patient selection. Of course, we have the standard clinical factor, prognosis factor, but now we see that new are arriving, notably the mutations of RAS and RAF proto-oncogene, and you see that in this multicentric paper from 3 tertiary centers, that the BRAF mutation and KRAS mutation have statistically significant worse prognosis for colorectal metastasis. This is all patients treated with CRS and IPEC. And the difference is not changed by the use of anti-EGFR perioperatively. Another important thing is probably the future of colorectal cancer. You know that since 2015, consensus molecular subgroups are identified for colorectal cancer. This was a publication in Nature Medicine, and the CMS4, the so-called the mesenchymal group, account for something that of 23% of the patients with a high stromal infiltration. These subgroups are determined by a genetic profile. And the Dutch studied patients with primary tumor and their peritoneal metastasis, and they proved that there were more CMS4 in primitive tumor and in peritoneal metastasis lesions. It was statistically significant, and CMS4 is associated with a poorer differentiation, higher inflammatory score, and a poorer overall oncological survival. But they also highlight that CMS4 status present a high intra-patient heterogeneity. Finally, to limit the risk of post-operative complication and improve result, we developed a perioperative clinical pathway that allow us to importantly decrease the failure to rescue rate from 9% before 2012 to 1% after. This was on our cohort of 666 patients treated on with cytoreductive surgery, and for 80% of them with also IPEC. So to conclude, we can say that from those recent data that expert centers complete cytoreductive surgery improves outcomes for colorectal peritoneal metastasis, which is the worst prognosis metastatic site. Extraperitoneal metastases do not contraindicate curative intent strategy, notably for liver metastasis. A strong rationale of intraperitoneal chemotherapy approach is impaired by the existence of various protocols, and so difficulties to analyze results. And the oxaliplatin high-dose based IPEC does not improve oncological outcomes, but probably increases severe postoperative complications. Further trials are needed to better define the good IPEC protocol in colorectal peritoneal metastasis, and to better identify patients that take advantage from this therapeutical strategy. The better biological characterization will help us to perform more accurate treatment, and don't have time to discuss precisely about it, but we have to find something to propose to patients with high risk of peritoneal recurrence. Thank you for your attention.
Thank you very much indeed. That was excellent. A lot of information there, and quite difficult to pick your way through.
Yeah.
Do you have any immediate questions? My question would just be about patient selection. How do you go about? You've told us that distant metastasis is not a contraindication, so liver or lung metastasis is not a contraindication. But are there circumstances where you would feel that it's not appropriate to proceed?
Patient selection is a very important point of this therapeutic strategy with a risk of severe complications. Of course, we process to a very extensive preoperative workup with almost in each case staging laparoscopy to evaluate very precisely what we will have to resect intraperitoneally. And after, in case of liver metastasis associated, of course we perform an MRI and look if we are able to perform parenchymal sparing hepatectomy. If this is the case and correlated to the general status of the patient and how he responds to preoperative chemotherapy, in MDT meeting we choose to operate or not operate.
Would you consider small bowel resections, or if the small bowel itself is involved?
Yeah.
Is that a contraindication?
Yeah, it could be. It could be. This is one of the major points with the mesenteric root retraction. The basic rule is to say that we have to keep at least 1.5 meters of small intestine. In fact, it depends also of colonic resection. If you have to associate colonic resection, it depends of the general status of the patient. But we never go further from 1.2 meters.
Yeah, of the DJ.
Of the small intestine.
Thank you very much. Can I just ask, the Prodige trial, is that the only trial that has compared cryoreductive surgery only with cryoreductive surgery in HIPEC? And if that's the case, is it the first one that's really showing that HIPEC, we obviously need to look into it further to look for the drug maybe that can help, but actually that, in fact, what we're looking at is that CRS is what we need to do, not HIPEC?
This is the hard questions. This is the only randomized clinical prospective trial comparing CRS and CRS-IPEC, except with the one I mentioned for ovarian cancer, that we had results also.
Colorectal,
yeah.
peritoneal.
In colorectal, this is the only. The Dutch are almost finishing their one, also with oxaliplatin, and it seems that results are equivalent to ours. This is a major problem for us. In Lyon, we were not really comfortable with oxaliplatin because we were used to use mitomycin C for a protocol with 1 hour and a half of hyperthermia. And we know from basic science that the effect of hyperthermia is very efficient from 1 hour. And of course, the results are, we see that there is really no difference, except perhaps for our subgroups, except perhaps for little differences. But we will probably perform a new trial with either mitomycin C, either cisplatin to be sure, because this is difficult to abandon a technique at the same time where it is validated in another histologies, just based on one trial, even if it was well conducted.
Thank you.
Thanks for this talk. I just got a quick small question, please. Last week, we had a 40-year-old female patient who came in with T4 cecal cancer, perforated with a few omental nodules and a few peritoneal deposits. So my boss said to me, you know, this is going to be a palliative resection. He tried to go as high as he could on the ileocolic artery, but we did not like really try to remove all the omental nodules or the peritoneal deposits. Do you think that we could have given this patient a better chance of survival if we had tried to remove all these peritoneal deposits?
This is a very important question because this is a very classic clinical situation. This is retrospective data, but we know from another study from the WENAP group that there is no real differences between, but this was with CRS and IPEC, between the treatment at the front line at the moment of the surgery and the treatment after, for example, 4 months of systemic chemotherapy. The important point is to have a clear evaluation of the abdominal cavity, which is somewhat difficult in emergency. And if you perform surgery, to be sure that you are CC0. But you can do it at the first time, and you can also do it with a second surgery. We have a protocol now in the unit for those patients. Your patient is the one at high risk of peritoneal recurrences. Even if you resect the small peritoneal metastasis at the first time and you perform systemic chemotherapy, those patients are at 70% of peritoneal recurrences in the 2 years following the treatment. So now we re-explore them, perform a second look at the middle of the systemic chemotherapy and discuss the CRS and IPEC at this moment. But we don't have so many data about this, and we don't know.
You interrupt their chemo to re-laparoscope them.
Yeah.
Yeah.
How often is that? How often? How many months apart? Or weeks apart?
So they have their initial resection. They're high risk.
Yeah.
You want to survey them. They're having their chemotherapy. When do
Yeah.
you stop the chemo to do the laparoscopy?
Yeah, for 1 month, 4
Okay.
to 6 weeks.
So soon after their.
But in this case, CRS is very. This is not extensive CRS because when they have peritoneal metastasis, it is a PCI of 3, 4, 5, and we don't have a lot of resection. Those patients leave the unit between 7 and 10 days after, and they are fit to retain a surgery, systemic chemotherapy.
Any other questions? No, it looks like not. Thank you very much indeed.
You're welcome.